I'm Amy Bohnert. I'm an associate professor in the Department of Psychiatry, also investigator with the VA Center for Clinical Management Research here in Ann Arbor. About 10 years ago, when I was working on my dissertation, I was doing research on topics of social networks and drug use and some HIV risk behavior work in inner city Baltimore. And as I was finishing up that project and doing all the writing, I had a friend who died of a heroin overdose. She had not been using drugs for several years and had been through treatment, but relapsed, and it was her birthday, and she was at a party, and people didn't really respond all that well because I think they were worried about getting in trouble. That certainly brought my attention to how big of a problem this is, although certainly less common than problems like heart disease. When it happens, it's really shattering for the people who that person was in their lives, and that death can be really hard to take. So when I came here to the University of Michigan for my fellowship and then into a faculty position, I was going through data of the VA has on their overdose mortality that they use for surveillance and for their self-evaluation on their suicide prevention efforts and other things like that, and was noticing how much the overdoses also seemed to be driven by what was going on with prescription opiates at that time. That there was this increase in opiate prescribing and a commensurate increase in overdoses due to prescription opiates specifically. So that got me interested in not just the issue around substance use and addiction, but also the issue around this overdose problem as an adverse outcome of medical treatment, or an iatrogenic effect, meaning something that's an unintended bad consequence of a treatment. There are a number of factors that have driven the increase in opiate overdoses. Certainly one of them is been the change in norms and expectations for pain treatment. There was a very valid initiative coming from a number of different quarters to improve the treatment of chronic pain in the country. And certainly it was undertreated before, and people were having a lot of problems with functioning and going about their daily life because of chronic untreated pain. Unfortunately, through a confluence of different factors, the easy solution to that, to the desire to treat pain more, was prescription opiates. And as we've seen with every substance through cycles of this over many, many decades, when there's more of a drug available in an area, there will be more harms from it. There'll be more people who develop addiction. There'll be more people who overdose and die if it's a drug that has the potential to cause harm. We saw that certainly with cocaine when crack cocaine became very available in the 80s. So not surprisingly, as there were more of these medications available, both for appropriate medical use, because it is a drug that has the potential for addiction, has the potential for harm, we also saw increases in harm. There's also the possibility that some of what we're seeing are just normal cycles in substance use. So I mentioned the crack problems in the 80s, and that was a point at which a particular drug peaked in being more used than other drugs for a time. And we've certainly seen that with other drugs over the years. So it's hard to know if we'd be seeing the heroin use that has increased in the U.S. in recent years without the prescription opiate problem preceding it. But it's possible that that also would just be a problem that would be concurrently going on, or that is concurrently going on. In terms of populations most at risk for harms of opioid use, pretty consistently what we find is that people with mental health concerns have much higher risk. And that's true no matter what kind of level of the issue you're looking at here. So if you're thinking about the overall population and looking at who's at most risk for having an overdose, let's say, people with a mental health condition are certainly at higher risk. In mental health conditions, I'm including the idea of substance use disorders, but it's true of non-substance use disorders like depression, anxiety, serious mental illnesses as well. That's also true when you take populations of people who are prescribed opioid medications for pain. In that group, you still find that the ones who are at higher risk for addiction and for overdose and other harms are the people with mental health problems, are people with certainly with diagnosable mental health conditions, but with poor mental health in general too. So more mild levels of depression. Those are going to be the people who are at more risk for experiencing harms from taking their medication. It's complicated because I don't think that the solution is necessarily to say, well, they shouldn't get as much treatment, right? We certainly shouldn't conclude from that that people with mental health condition aren't entitled to the same level of pain care. It's just that I think we need to be more aware of the safety issues and also be thinking more about some of the alternatives for pain treatment. In terms of what the potential explanations are for that, I've long been interested in this issue of the intent of overdoses and the ambiguity of that. So a lot of the surveillance reporting around overdose puts things into pretty neat and tidy categories. You have your suicides, you have your unintentional overdoses at the other end of the spectrum, and medical examiners use a third category called undetermined intent that is essentially them saying they don't know what it is. And that's actually a pretty small category in terms of the total numbers of overdose deaths in the U.S. I think that it's much more likely that the intent of overdoses occurs along a spectrum. So you have people who are very clearly attempting to take their own life when they have an overdose, and you have people at the other end of the spectrum who perhaps forgot that they had already taken a medication that day, took an extra pill, and that happened enough that maybe it caused them to have an overdose. Probably some cases in the middle there too, right? It's easy to intuitively think about the idea that there may be people who are depressed, feel some hopelessness about the future, but certainly aren't at a point where they're trying to take their own life, but that sense of hopelessness leads them to riskier behaviors in terms of their medication use, in terms of also drinking, that would increase their risk of running into trouble with that. It's important to understand what medication-assisted therapy is and why it's important for the treatment of opioid use disorders. So when someone's at a point where they're having problems with their opioid use, it's causing them a loss of functioning. And what I mean by that is it's causing them to not be able to go about their life the way they did before. Perhaps it's causing them to not perform as well at work. It's hurting their social relationships. That's a point at which we'd say someone has an opioid use disorder. And the gold standard of treatment for opioid use disorders is medication-assisted therapy. What I mean by that is the combination of counseling or other therapeutic interactions with others, whether that be peer support, whether that be with a social worker or other type of counselor, and a medication. And the options for that are three. There's methadone and there's buprenorphine. So both of those are opiates themselves. They are developed in a way that makes it so that someone doesn't experience the highs they experience when they're using the opiate they had been using before in a way that was causing them harm. And it also reduces their cravings. The third option is naltrexone, which is a non-opiate medication that specifically just targets cravings. A lot of concern about medication-assisted therapy is the idea that using the methadone or the buprenorphine, or Suboxone is the brand name for that, instead of the drug that they had been experiencing problems with, is just swapping one drug for another, right? They're both opioids. It sounds like, what have you really changed about their situation there? The important thing to understand about addiction in general is that it's not about the taking of a substance. So I had a coffee this morning. I bet a lot of people have coffee in the morning. I do that every morning. I would go through withdrawal if I were to stop, but that doesn't mean that I have an addiction to caffeine. That's simply just the substance-taking behavior and the experience I have of trying to stop it. Would have an addiction to caffeine if I was having cravings throughout the day for it and having other ways in which trying to obtain caffeine was causing me to be impaired and not be able to hold down my job or not be able to have good relationships with my family, and it was causing me harm. So when someone's taking the methadone or the Suboxone, the intent is for that to stabilize their cravings, but allow them to work on their functioning, work on their ability to go through life in a normal, full way, and address the functioning issues that result from the substance use disorder, while the biological issues that happen because of taking a substance for a long time are managed through the medication. It's important to help people who are misusing opioids and help them make their use safer, more appropriate, more in line with how it's prescribed to them if it is prescribed to them, or avoiding use if they're, say, getting it from a friend. And I think something that's not as well understood as some of the other parts of the problem is helping people who have just a low level of use. So they may be occasionally taking an extra pill, and that does carry some risks for them, but they're not at the point where they have an opioid use disorder, I'd say. We did a study in the emergency department here at University of Michigan where we recruited people who were waiting for care at the emergency department and acknowledged that they had recently had some level of opioid misuse in the prior 3 months. And we did a brief, about a half-hour session with a master's level therapist where we talked to them about their opioid use and talked through ways that they could handle their opioids safer, ways they could make sure that other people that live with them perhaps are not accessing their opioids, how they could talk to others who they're worried about for their opioid use, and how they would respond if they saw someone else overdose. So really tried to address a couple different key public health targets in terms of opioid safety in one intervention. What we found was that doing that therapy session compared to just giving someone some educational brochures, the people 6 months later told us that they had lower levels of opiate misuse and fewer overdose risk behaviors. So we did find that it appears that that type of intervention is effective. I'd say that it's still somewhat early because we haven't done it in a study large enough yet to connect it to true health outcomes, like whether or not people are more likely to have an overdose in the future. And we're doing a couple studies now where we are going to be able to look at that more. But I think in terms of what should be done next, I think certainly taking that counseling approach to people, and a brief counseling, not real expensive to deliver, to people who aren't at the point where they need intensive addiction treatment, to help people use their medication safer, is something that's maybe getting missed some with how much focus there is on just changing prescribing. If someone has a family member that they're concerned about, there's a couple different things they could do. I think it's always important first to talk to that family member and do it in a understanding and sympathetic way. So there's a lot of stigma about addiction, and it makes it a hard thing for people to talk about. I think we could all imagine if that we were having a substance use problem ourselves, having someone that we know loves and cares about us bring it up with us in a caring way could make a big difference in how easy it is to talk about that and easy it is to consider getting help. And I think another thing to think about is helping the person talk to their primary care provider or another doctor about their issues, particularly if the opioid misuse problems are related to an opioid medication that's prescribed by that doctor. I think a lot of people will find that intimidating to do or scary because they'd be afraid that their physician would say, well, that's it. You're telling me you're having problems. I'm not giving you any more opioids. And then their pain isn't going to be treated. So I think it's important to do that in a thoughtful and careful way. And I think most physicians would appreciate someone being honest with them about problems that they may be experiencing with the medication and really seek to help both the person address the safety of their use of that medication, but also get access to other modalities of pain treatment that could help address the need for pain treatment if the person's having enough problems with their opiates that they really do need to stop taking that medication. I think if someone is at the point where it's clear that they have an opioid use disorder, that it's causing them lots of harm in their ability to function, then it's best to help that person get into addiction treatment specifically and as soon as possible. So certainly working through one's insurance. There are, in most places in the U.S., there are state hotlines you can call to find where the nearest treatment is. The SAMHSA website, the Substance Abuse Mental Health Services Administration, has a buprenorphine treatment locator, so you can type in your zip code and find out what physicians in your area provide that treatment, which is the best treatment for opioid use disorders in terms of the outcomes for people. In terms of the roles of pharmaceutical companies in this problem, it's hard to debate that the pharmaceutical companies don't have a financial incentive to downplay the risks of opiates. That's true in the past, and it's true now. There's been a lot of attention to Purdue Pharmaceuticals in particular, which is the maker of extended-release OxyContin, and they're somewhat unique among the drug companies in terms of not having medications that aren't opiates that they're making a lot of money from. So I think that financial incentive to downplay the risks was particularly strong for them, and they've certainly been more the attention of fines and of lawsuits and settlements related to those harms, although some would argue that the amount of money they've had to pay for that is not nearly proportionate to the amount of money they've made off of those harms that have occurred. For me, what that highlights is the importance of close oversight from the FDA in terms of the medications and their safety that perhaps was lacking in the past, and also close oversight of the marketing. Certainly a lot of the problems were caused by the role of pharmaceutical companies in understating the risks specifically to physicians, but also to patients, and that the marketing messages that are put out there, I think, need to be much more closely regulated. I think solving the opioid crisis will require three main components, and they occur along the spectrum of severity. So the first, and what I think of as the least severe level of problem, is improving prescribing practices. There's been a lot of movement here around improving the functioning of state prescription drug monitoring programs, which allow physicians to go in and see what a patient's prescribed and be able to be more aware of potential interactions with other medications that could cause harm. There's also been just general efforts to reduce the number of people who are getting really excessive amounts of opioids that have the potential to result in harm to them or also to other people who live with them just because of the pure quantity of it. There's other things that can be done to try and reduce the number of opiates prescribed after surgical care, because that's really excessive as well relative to how many people are typically needing and taking. And that's really about addressing the supply issues. In the middle, I think we need to do stuff to help people who are perhaps experiencing some light harms of opiates but aren't at a point of having a full-on opioid use disorder. Some of that will be helpful by reducing supply, but if someone's at a point where they're having some problems or do genuinely need to use opiates for a pain problem, say they had a surgery, but they also have a history of substance use disorder, doing some additional counseling and help to those people and more behavioral management approaches to help reduce the risk will be important. At the other end of the spectrum of severity, in our solution number 3 is improving access to medication-assisted therapy for opioid use disorders. So just eliminating supply isn't going to help people who are at a point of having an opioid use disorder. They're going to find other sources of supply, and certainly there's concern, although the connection hasn't been fully made, that some of the increases in heroin use we've seen are because of people losing access to prescription opioids after the point at which they already have an opioid use disorder and having to try and find other opiates to deal with their addiction in the absence of having good access to treatment. So there's not nearly enough people who provide medication-assisted therapy currently in the country relative to the number of people with opioid use disorders. We need more physicians and other prescribers to be willing to provide the treatment. We need better access to the counseling that goes along with it. We need better reimbursements for that treatment. We also need to address the stigma that prevents people from being willing to seek that kind of treatment and take on the acknowledgement of the problem that they're experiencing. Also stigma from the provider end in terms of not seeing the patients who need that treatment as ones that they just don't want to deal with because they're a difficult, population and having negative views of it. So it's a complex problem, but I think that addressing those barriers to access for the medication-assisted therapy are actually a really critical part of addressing the problem as well.